Impact on microaxillary mechanical ventricular support is a very complex title. Means Impella support in patients with cardiogenic shock. Can we improve something? And I'm really grateful to Dr. Kapoor that I could skip 5 slides in my introduction just to start right away. My conflict of interest is here, and Bill, we started in 2013, copied something what Detroit organized for the first time, means standardized team-based care for cardiogenic shock, and we organized a regionalized system of care in the middle of Germany, and we saw in our patients that networking improves outcome. We now oversee 2,170 out-of-hospital cardiac arrest patients which were admitted to our university hospital in a range of surrounding 65 kilometers, established a cardiac arrest center, one of the first ones in Germany, and transferred patients either by air or by any kind of medical transportation directly to this, via cath lab, to the cardiac arrest center. In these patients, we implanted 426 Impellas, 221 VA ECMOs, some ERBPs for our heart surgeons, just for our heart surgeons, and saw a survival rate between 45% over 6 months and 12 months, survival of 41%. These are the data. In this population, we observed that following the protocol of the US Pella, when we implant after first medical contact to pre-PCI and Impella, which is a time between 65 minutes plus minus 70 minutes, then we see a significant decrease in lactate levels and in the vasopressor score over a patient population in which we implanted post-PCI, means 25 minutes later. So far, STEMI DTU, there is something going on in these 30 minutes. This results also in a significant improved survival of these patients, but not only that, we saw a significant recovery of the left ventricle in these patients, pre-PCI, the red boxes, but coming to today's topic is we hardly observed in the pre-PCI early implanted Impella patients hardly any acute kidney failure, as you see here in the green bars. And we ask ourselves, what may be a reason, and do we have any topic, any tool in our hands which we could use to improve and to measure in these patients kidney failure? We went ahead and tried to start renal scintigraphy in patients with Impella in shock, carried them to the nuclear medicine department, carried them back, intubated, not intubated. It was a hell of a time. We stopped at 7 patients. We saw a broad variation. Renal scintigraphy is a very good tool for stable patients to see to measure renal perfusion, but not in patients with either a combination between cardiogenic and septic shock. So this was dead-end street. I just looked it in my dictionary, cul-de-sac for French, or in German, Sackgasse. So we went ahead, talked to my renal friends from the historical when I was house intern, and they advised me, Jörg Rademacher, who published this New England Journal paper in 2001. He's now head of nephrology in a very large hospital in the middle of Germany. And he published renal resistive index measurements by Doppler ultrasonographic measurements to predict the outcome of renal arterial stenosis. And he published a year later a transplant survival using the same device. The renal resistive index measurements is the only measurement which is established in critically sick patients, and it might have a prognostic value for cardiovascular events, particularly in elderly patients. And RRI is the only tool which you could use when you have support devices in the setting, as reported by our cardiac surgeon. Now, we did this little measurement, measured velocity in the renal cortex of cardiogenic shock patients 24 hours after admission to our hospital, stable on inotropes and vasoconstrictors. and measured velocity systolic, velocity diastolic, and calculated the resistive index. And this is a work which has been done by these two nice ladies, which are heading our cardiac arrest center, Birgit Markus and Susanne Beetz, and they published it some weeks ago. What we saw in standard patients, just coming in all comers, that when we increase Impella support by 0.5 liters, and it was our goal not to increase mean arterial pressure, similar to what Dr. Kapoor showed you in the pathophysiology, because then you're altering too many parameters. What we saw is MAP remained stable. Very important, and keep it in mind. In this setting, you increase Impella and you decrease systolic pressure, but you increase also in the same moment diastolic pressure, meaning renal perfusion increases. And this results in a decrease of renal resistive index, meaning that the resistive vessels within the renal cortex are relaxing. So you get a better flow, a better pulse wave, which we also measured. This simple finding, just a slight increase in Impella support, results in an improvement of renal perfusion. So microaxillar mechanical support by Impella device in otherwise hemodynamic but shock patients led to a significant reduction of the renal resistive index without affecting systolic or diastolic blood pressure. This observation is, I will be very cautious, consistent with the notion that Impella support may promote renal protection by enhancing renal perfusion. Nevertheless, if you're too late, if you're running behind the shock, patients is increasing abdominal pressure by congestion or the lactate levels are increasing, then renal resistive index is a difficult parameter to use. For us, for my team, take-home message is we not only have to be ahead of the cardiogenic shock in infarction patients, we also have to be ahead of acute kidney injury. And the renal resistive index is a good tool, easy applicable, cheap, and to be used everywhere in order to protect from acute kidney failure. Currently, we are running two larger steps where we randomize patients in protected PCI and cardiogenic shock on a RRI-based Impella treatment plus minus RRI in protected PCI and cardiogenic shock. And thanks to my team, they did the work. I just have the pleasure to present it. Thank you very much.
Yeah, Bernhard, thank you very much for this very nice illustration. And one question with this ultrasound measurements arises when you use it kind of serially on your ICU in shock patients on support with Impella. Do you also use renal resistance index, for example, in borderline patients with elevated lactates after resuscitation to detect end organ damage?
Interesting question. We use it currently just to get a hand on this parameter, where is it used for or not. Old patients which come in with congestive heart failure, filled up with water up to the ears, and we measure how much furosemide IV can be used without affecting renal function. And these are little tricks, and it's a helpful tool just to manage these patients. Also, if you have old patients with an reduced GFR and slightly elevated creatinine 1.2, 1.3, you measure whether their volume status is okay in order to prevent contrast agent damage in these patients. These are tools where you could, these are clinical settings where you can use RRI in order to improve your treatment management and to avoid acute kidney failure, because we don't have any other measurement available at that time, which is fast.
Okay. Question from the floor?
Very interesting experiments. I have two questions. In regards to index, as I recall, one of the reasons it really didn't catch on to clinical practice was the variability of resistive index. Apparently, it's not very easy to measure. It requires a lot of basically training for the technician who does a measurement. And the other question I have is that, did you measure the abdominal pressure? Because there is a strong correlation between AKI, either in the form of acute or chronic, but specifically in the form of acute cardiorenal syndrome, with the intra-abdominal pressure, especially in patients who are severely congested.
Very good and very tricky question. Yes, we do. We measure intra-abdominal pressure, because intra-abdominal pressure is one of the major factors in these septic or cardiogenic shock patients, which is via compression affecting renal perfusion. That's why I said you have to be ahead of not only of the cardiogenic shock, but also of the renal failure, because once the renal perfusion decreases, the fluid goes into the third space, and it alters your measurements dramatically within 1 or 2 hours. Point one. And point two is we trained our youngest doctors on the ward, and the more experienced doctors on the intensive care, 10 of them, and it took us a week to have them safely and repeatedly good measure determinations of the RRI in these patients. So it's not that difficult to learn. Even I could learn it. Well, I learned it.
Very, very last and short comment or question, Naveen, please.
Yeah, so that was really great. I had 2 questions just to clarify. One was, you said that did you titrate the Impella to achieve that 0.44 liter per minute increase? Or I just want you to clarify the statement on how much support, or if there's a dose response, what's the level of support?
We increased it by 3 steps, let's say from 5 to 8, and then decreased it until the MAP was in its baseline levels. So we went up above the original MAP and then dropped it again. This was most of the time just one step ahead, and we ended up with 0.44.
Okay, so just to clarify, so you weren't running all the Impellas at maximum speed through the study?
No.
These are shock patients, though?
Shock patients. Our SOP is to decrease the vasopressor as fast as possible. Most of the time it only takes 12 to 18 hours. And then adjust the Impella just as much support the patient needs, not over supporting the patient. What for?
Okay.
There's no need for.
Yep.
And the importance in this trial was the patient had to be stable on Impella level X with a vasopressor level X for 6 hours prior to the measurement.
Okay, so that's what I just wanted to clarify then. So really you're saying that you think the augmentation in diastolic blood pressure instead of the total mean arterial pressure going up, it's just the augmentation of diastolic blood pressure you think is the key element that protects the kidney in terms of hemodynamic responsiveness to the Impella?
This was just proof of principle in this trial. What we do now is, in the shock room, we measure RRI in STEMI patients to see whether kidney function is already becoming decreased. So, and the preliminary results we saw from the first 15 patients is that it's even better to measure it as following first medical contact directly in the shock room when you see that the kidney function is about to drop.
Okay, got it. Thank you.
Thank you very much.